Thank you.
Start?
Yes,
Okay.
please. Thank you.
Well, first of all, I want to welcome everyone that are here with us. I want to say specifically that we have many professionals with us, and it's very exciting to have all of them together in this webinar. But also, we have the students from the Tel Aviv universities from the two tracks, both the Israeli tracks, the master's program on emergency and disaster management, and the international track. The international students, many of them are here in the class. Right now you see me, but there are many of us in the class, so we all are together, and it was a wonderful opportunity to have the opportunity together to understand how two main issues, the COVID-19 on the one hand and humanitarian crisis on the other hand, actually be connected so that we can understand how the COVID-19 impacted on humanitarian settings. So we are, as I've said a few minutes ago, we are privileged to have Professor Spigel with us here today, and we'd like to thank you from the bottom of our hearts for being here. I'd like, with your permission, all of you, to just very briefly introduce Professor Spigel. He is a Canadian physician by his training. He's internationally renowned professional for his research on preventing and responding to humanitarian emergencies, especially focusing on refugee crisis. He is a director of the Johns Hopkins Center for Humanitarian Health and a professor of practice in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. Before that, he also was the deputy director and the chief of public health in the United Nations High Commissioner for Refugees. As well, he also worked in varied institutions, for example, the CDC, the American Center for Disease Control, as well as for MSF, Medicine Sans Frontières in refugee emergencies. So as you can see, we're having the ability here to have to speak to us someone with a vast amount of experience, of insight, of the opportunity of experiencing firsthand all of these different crises, and we are going to share that. So thank you very much, Professor Spigel, for being with us here today. And the screen is now yours.
Great, thank you. Good afternoon to all of you. It's a pleasure to be here. Also, I can add that I studied my junior year abroad at Hebrew University, and so I know Israel very, very well. That was political science that I was studying there a long time ago, but I go back and forth to Israel often, so it's a pleasure. And in fact, I was telling Dana and Maria that I had lectured at Tel Aviv University maybe 2 to 3 years ago, obviously on a different topic. COVID wasn't there at that time. So I'm thrilled. I'm going to share my screen right now. Can you hear me well? Yeah, okay, great. Okay, and I'm going to move this around so I don't see it. Okay, great. So I'm going to talk to you about primarily three different areas. Don't expect a huge amount of answers right now because unfortunately the data are very, very poor, but let's start and see. So I'm going to start with, and the majority of the discussion will be on COVID-19 in humanitarian settings. Then I want to talk a little bit on human rights and equity with a concentration on the vaccines. And then move into something that I found very interesting but very frustrating, is the use or abuse of public health orders. And I'll concentrate primarily here in the United States and how it's affecting asylum law. I looked last night. I could not find the latest, at least published by HCR, but we know that there are over 80 million, probably 82 million now, refugees. It usually comes out, so it'll come out June of this year, I assume, the next iteration of this. We often talk about and concentrate on refugees, and often refugees in camp-like settings, but to emphasize a couple different things. Number one is that internally displaced persons, those that have not crossed a border, as you can see, are nearly double the numbers of refugees. And then number two is it's very easy, and I've done this in terms of studying, researching inside refugee camps because it's a much easier environment. But most refugees and IDPs are actually not in camp-like settings, but they're dispersed amongst host populations, and they are less studied, and they're more difficult to be able to actually reach. This is a OCHA, the slide, the UN Office of Coordination of Humanitarian Affairs. And this is just an example of, I checked it last evening. What they've done is they've included all of the countries that have humanitarian response plans, or HRPs, for this year. And they're doing a running total of how many people are affected. Many of this is surely an underestimate, particularly in many parts of Africa. There just aren't enough tests being done to actually really know what is happening. And I'm going to concentrate a little bit more in detail, doing a deeper dive into the refugee camps actually in Bangladesh. But the refugees are stateless people from Myanmar. Trying to get to the next one. Okay. So early on, I guess in March and April of this, is it this year? Yes. No, last year. Yes, last year. Wow, time goes quickly. We were very concerned, as I think many people were, with COVID. It was really at the beginning where we had most of the data was from China and a little bit from Europe and very, very little from the US. So it was very, very early on, March and April. But we wanted to sound the alarm that from what we heard about, refugees, and in this case, refugee camps, because of the high density and some other aspects that I'm going to speak about, would have very, very high mortality, very high transmission rates, reproductive rates, R-naughts, and likely very high mortality. And we were concerned about hospital occupancy and the ability of the health system to cope. So why were we concerned? I'm sure you're all familiar with the Rohingya refugees. Its population that we're studying is 600,000 was in the main mega camp, but there are just less than 1 million in the broad numerous the refugee camps that are located here on my left. You can see the numbers there of all the camps in Cox's Bazar. Incredibly high density. A previous study and another one that was just published yesterday on a diphtheria outbreak there showed an elevated transmission. And we knew at the time that there were relative to the numbers, very low number of hospitalizations and low beds per 1,000 people. So what did this mean in terms of COVID? I'm not a modeler. I worked with colleagues at Hopkins to model with all of the caveats that we were dealing with data early on, and as we all know, we've learned a tremendous amount since then. And this was without interventions because we also didn't know, and we were concerned about non-pharmaceutical interventions like physical distancing. We knew there was poor water sanitation. So what we wanted to do was not to predict what would happen, but give different scenarios so that UNHCR, the NGOs, WHO, and the Bangladesh government would be able to prepare. So this is what we came up with early on, and we did 3 scenarios here. The red, which is a higher R-naught, a high transmission that was higher than what we were seeing in China at the time, a moderate transmission of what we were seeing in China at the time, and then a lower transmission scenario, which we thought was unlikely. And not surprisingly, we saw that given early on, there were so many more tests amongst people that were already symptomatic, that there was a high positivity rate. And so these, we've learned over time, were an overestimate. But even in a short period of time, within 100 days, Then when we look over here, around 200 days, then ultimately 300 days, we would see a significant amount, or we estimated that a significant amount of the population would be infected. And I'll talk about the deaths. Now, one of the things that we realized early on, just from the data, early data, that really hasn't changed significantly at this point is the age and severity of death. And so we tried to look at the population age distribution. This is the Rohingya camp in the Kutupalong camp. And you can just see, not surprisingly, the age distribution is much more of a classic pyramid, and a significantly larger amount of people less than 10 to 19, and particularly 0 to 9. This is Bangladesh overall, and this was China. And so, and here is just showing the severity of the disease as one's age increases. So although we had predicted that there would be a significant amount of death, we believed proportionally there would be a lower amount of death amongst the Rohingya in the camps than there would be overall in Bangladesh, China, US, we use Switzerland and Italy. And this is based purely on age. This is based purely on demographics with no interventions. Okay. The other area, so this was really meant, it was very early on, and it was meant to be a warning to say the transmission is likely going to be high. The numbers, and this was an example of the hospitalization and the bed capacity. And at the time there were 340 beds, but there was already discussion that they would move up to 630 beds. And so we tried to look at the current number of hospitalized in the high capacity, and it would eventually go up to something like 2,000 people that would be hospitalized. I'm sorry, 20,000 people. So a huge amount of, here was 5,000 years. So we knew this was to try to show them that the daily hospitalization rates would be significantly high and that they would need to respond. So what happened? This was early on. I'm trying to look at the date here. If it is, oh yeah, April 2022, showing that distancing would be extremely difficult in these refugee camps and that everyone's racing to avert a coronavirus catastrophe. Isolation treatment centers open. So they did prepare. And I think the report was an eye-opener for them to say what could happen. But what has actually happened so far, and this is actually, I put it down here, it's a wonderful live dashboard that WHO has put up for Cox's Bazar specifically, and then the Rohingya communities. So just walking you through these three slides here, when we look at tests per million, at the beginning, the tests were not many tests in Cox's Bazar and amongst the Rohingya camps, but UNHCR bought and put in PCR machines, some mobile PCR machines very quickly. So if you look here per million, which is the best way to look at it because of the population size. So far there have been about 25,000 tests per million in the host community. This is in Bangladesh, in the host community in Cox's Bazar surrounding the Rohingya, 22,000, and 37,000 tests amongst the Rohingya per million population. So it's significant. We cannot at this point say that testing is very, very low, and that may be one of the reasons we're seeing high positivity. And amongst those tests, the percent positive, very high in Bangladesh, lower amongst the host community, and very low. So very low positivity amongst the Rohingya, which is not what we would have anticipated. Now, here are the numbers of cases per million. Again, do we see low test positivity? So it goes down again. Overall in Bangladesh, the host community, and amongst the Rohingya, we see a very low, compared to the rest of the country, very low numbers of cases. And then finally, deaths per million amongst the Bangladesh host community and the Rohingya, lower than expected, although we would expect lower, but not by this amount, but we would expect lower just because of the age demographics that I mentioned. So I'm going to try to go to the next slide. So there's a lot of questions. Why? And this is just one example. This was an IOM study that came out in July 2020. Very, very interesting. And it was not statistically or probabilistic in the way they did the study. I would say more qualitative, but still quite interesting. And I'll let you read these quotes on the side while I speak. But what we gathered from here was, number one, many of the Rohingya were very anxious. We've seen this throughout. When someone comes to a clinic and they are just suspected of having to be COVID positive, in Myanmar itself, in the Rohingya areas, the camps, and many other places around the world, they are automatically quarantined. So they're taken away from their family. And you can imagine no one particularly liking that to happen, wanting that to happen. But for refugees who are already mistrustful of governments, mistrustful of authority, that is going to be like we saw in Ebola when you quarantine a whole village or a city in Liberia. It's not going to go over well. And there's a lot of thinking and belief that a lot of people were not coming to be tested. Secondly, as you may be aware, the Bangladesh government has developed an island off of Bangladesh, and they want to move a significant amount of Rohingya there, and that's very, very controversial. So there were a lot of rumors that anyone that was found positive or suspected to be positive, this was early on, would be moved to the island. So consequently, at least anecdotally, there were the Rohingya through the studies talked about not going to the clinics, hiding, going elsewhere, and hiding their dead if there were death rates, specifically for this reason. So one of the big questions across the board right now, and what I've mentioned and shown here for the Rohingya is just one example. But we do not know what's happening in Syria. We do not know what's happening in Yemen, despite some interesting studies that have been looking at satellite images of graveyards, etc. So is transmission and the effects amongst these populations different? There's a lot of questions already compared to the high-income countries and low-income countries. We're seeing many countries in Africa apparently having either fewer infections and or fewer deaths. Is it not being reported? Are we missing it? Another one that could be another interesting aspect is, could it already have happened and we just missed it completely, meaning very, very high transmission? Another area that we're looking at, we're studying in 3 different countries right now, in Bangladesh, Democratic Republic of Congo, and Central African Republic, is beyond looking at COVID, is looking at the indirect effects. And could some of the indirect effects, I don't want to say I have here worse, that's not really fair because it's pitting one against another. But we saw in the Ebola outbreaks, both in West Africa and in DRC, that there were higher numbers of deaths for malaria, for example. The effects of reductions of people going to clinics, of either healthcare workers not going to clinics themselves early on because they were anxious about being infected, and or people just becoming sick because healthcare workers are at higher risk. How has this affected maternal child health, antenatal care, maternal deaths, infectious diseases, and non-communicable diseases that require medications that they may or may not be getting? So a lot of these things we do not know. This is what we do need to work on, is some of this we're working on, some of this is just still very, very poor quality. Surveillance data. We need to be examining the surveillance data, and we, at least for these 3 countries, have a lot of the surveillance data now available. It can be rather sketchy. Number 2 is the mortality data. We need to be able to look at not just what is being reported, but trying to work with communities to better understand what deaths are and how many deaths have occurred. A lot on RCCE, on risk communication and community engagement. We know from most epidemics, Ebola was very, very clear. And now with the coronavirus, that there's so much miscommunication. And so what are the people understanding? And this is important, not just for going to the clinics and seeking help, but also for future vaccination. Interestingly, and there was finally, it's taken a while, there have been very, very few serological studies occurring amongst conflict affected and forcibly displaced populations. WHO and the government did just finalize, I think last month, a serological survey for antibodies for COVID amongst the Rohingya, and we're waiting for the results. And then finally, we need significantly improved monitoring and evaluation. One of the big issues when we did actually get access to the line list for COVID in the Rohingya camps, it was poorly done, and we couldn't actually, we couldn't come to any conclusions for the most part using the data because it was very poor and it wasn't clear for the testing, how many were context, how many had symptoms, how many were asymptomatic. So there needs to be a significant increase. After we're going to be publishing soon another paper looking at various data, triangulating the data in the Rohingya camps. My guess, I would say at this point, or hopefully an educated guess, is that there's been significant transmission within the Rohingya already, maybe 20, 30, 40%, that we'll find that in the serological survey. But for a variety of reasons, the death rates have been, the mortality rates and the hospitalization rates have been lower. And there could be a lot of reasons for that. Everything from previous infections, whether corona or other coronavirus or other viruses, even some parasitic diseases that we may see may be protective. Certainly they're outside much more, and the weather could be some components. There's discussion about whether BCG vaccination can be protective. There's just so much we don't know at this point, which is actually quite disturbing. I will move on because I want to have, I'm just looking at the time, I want to make sure we have time for questions. So I'm hopefully end in about 10 minutes. The next discussion the next area I wanted to discuss is human rights and equity. And I just have, I think, for this and the next section, 3 slides to bring over some points. We've seen constantly, and the parallels, at least for me, that I see between early on HIV and access to antiretroviral therapy is very similar and playing out here as well with COVID. We have seen a tremendous amount of either misinformation and deliberate information saying that the Rohingya refugees are actually fueling COVID, which we know is not the case. But we've seen this across the board: Syrian refugees in Lebanon and Jordan, an increase of anti-refugee sentiment. And we're seeing UN is trying to counter some of the pandemic-related hate and xenophobia. It's been very, very evident, and it's come out now in terms of vaccine equity. So early on in the paper that we wrote, looking at the Rohingya, what we wanted to discuss, because we saw this with antiretroviral therapy for HIV and AIDS, is to talk about vaccine equity early on. I think we did anticipate, but the extraordinary lengths that governments such as Israel, the States, many parts of Europe and Canada, it surprised me to a degree the amount of push they've had on providing vaccines to their own population at the expense of others, whether it be the Palestinians, whether it be here in the US. We've seen the inequity between minorities, and particularly we're very concerned about the undocumented migrants, of which there are tens of millions in the US, not getting this vaccine. But equally so, we're concerned that with an understandable emphasis on one's own population, we're not thinking human rights, but also from a public health point of view. If we don't start dealing and getting vaccines to other countries, we are going to be seeing, as we all know, the variants that are going to be reinfecting us, and eventually the virus will be mutate sufficiently so that our current vaccines will not be able to address the mutations. Therefore, we'll have to revaccinate everyone with boosters, etc. So the short-sightedness in terms of how governments are dealing with vaccines has been, perhaps, well, not surprising, extraordinary. And what we have been arguing consistently, I don't know if it's here yet, is we did a global call to include in the Lancet for inclusion of migrants and refugees, is we've been offering not just a human rights argument and an equity, but also a public health argument, which I think is becoming more and more alert and stronger now as we see the variants growing. Very concerning, particularly in Brazil, what is happening. But my next point and my next last section really deals with this. One of the frustrating parts is that it's easy to do global calls and publish in the Lancet to say how important this is, but it's much harder to get governments to actually listen. And we're seeing that for the most part, they're not listening. So let's now my last discussion, and then I have one slide on some of the future, how COVID may be able to actually change or transform some of the humanitarian assistance. Public health orders and asylum law. What we've seen here in the US in March 2020, CDC put out a rule that said on both sides, Canada and Mexico, but they were really aiming at Mexico, because of COVID, there's going to be stopping anyone migrating into the country. And this could be people, economic migrants, but also asylum seekers. And as we know, that's against the 51 Refugee Convention and also United States law that people who are fearing persecution should have the right to cross over, seek asylum, and be protected. Now, one can argue, and we're going to have over the next many years, discussions about international health regulations. Should borders be closed? Should they not be closed? But from a public health point of view, I don't think one can argue that we should have a partial closure of a border. So what happened here was this was a deliberate attempt by the Trump administration to say that another way to stop migration from occurring, particularly from the south, from Mexico and the Northern Triangle, into the US, but Americans, green card holders, commercial traffic, and many, many exceptions throughout since March have occurred. So that, and so therefore there were many people. It was still a very porous border. So it was a flagrant.
But you are on mute.
Professor Spigel, you're on mute.
Yeah, I don't know what happened. I'm back. So this was a deliberate attempt, and we've seen this across the board, particularly we've seen it in Greece and we've seen it in Hungary, amongst other countries. So there's been a deliberate attempt to abuse public health laws for COVID that do not have the intention of actually affecting COVID transmission, but are specifically trying to target asylum seekers and migrants. This law this is called Title 42, and it's actually still in existence right now, and the Biden administration has not yet rescinded this order. We all have a problem with it, saying they should rescind this order. On the other hand, being not just an academic, but being someone who's been doing operations for much of my life, we also have to be practical. And if you rescind this Title 42 order, we're already seeing a massive number of people crossing the border and into the US right now from Mexico. So how do we try to address both the COVID risks as well as issues related to trafficking? And so the Biden administration will likely get rid of Title 42, but they're going to have a big problem in terms of how, during the time of COVID, how do you ensure safe and orderly migration? Me, I think the second last. So we did again, and I'm getting tired of doing it. I mean, I think it's better than not doing anything, but we wrote, a group of us here in the primarily US public health experts wrote to, at the time, Alex Azar, this was the Secretary of Health and Human Services, and Robert Redfield at the time, the Director of CDC. There was another rule that came out much later. It's still on hold for the moment, but this was to expand, this was by the Trump administration to expand this so that other diseases will be included, in even diseases such as syphilis or gonorrhea, because they've been traditionally screened for migrants coming over. So there was another rule that was proposed to expand this significantly for the future. It's currently being considered, but likely with this new administration will not go forward. And so we did our usual of writing to these people. We did get letters back, but they were from the previous administration saying, thank you very much, but ignoring it. And then we've written commentaries on this, trying to explain why public health orders should not target asylum seekers. So I have two last points. This is just a brief summary of the key points, and then I want to discuss some possible future ways forward. So sadly, we still do not know enough about the SARS-CoV-2, the virus itself, and the COVID-19, the effects of the virus in general, and in particularly in humanitarian settings. We need, and we've been asking for this for a long time, a structured and protected data sharing agreements. We do have this now with UNHCR. The concern is that data being shared with whomever doesn't really make a difference. If it does get out publicly, this could be used to increase discrimination against refugees or internally displaced persons or economic migrants, and it is true. So, but on the other hand, if we don't share, which is what was happening and continues to happen in many settings, we're not going to be able to learn from it. So we need to figure out a way that we can have some sort of agreed upon sharing, but the data has to be very, very carefully protected because the misuse of this data could be extreme. We need to continue to document and mitigate some of the indirect health consequences of the pandemic. It's consistent across the board with whomever I speak with, NGOs in the field, that they've mentioned that they have concerns about particularly non-communicable diseases, the future of just simple childhood immunizations. But when we talk about it and try to document this, it's not there. The documentation has been very, very poorly done. There's been discussion in Yemen and Syria. COVID may not be a priority for some of these people when you have bombs falling and you're on famine-like conditions in Yemen. So there's this weighing up of the various policies and how policies are and will be implemented in terms of quarantine for different settings. And then finally, I think we need overt discussions on the future treatment and vaccines agreements ahead of time to make sure that we can get these treatments and these vaccines to people across the globe, and not just for who is either done the R&D or who has the money to be able to actually say we're going to pay for it. There's a lot of discussion right now, but both Europe and the US are actively trying to say to other countries like India that you're not going to be able to do generic creation and reproduction of the vaccines, the whole TRIPS agreement. And this is primarily because of US R&D and European R&D, as well, research and development, as well as the strong push by the companies, the pharmaceutical companies, to say, we don't want this to be right now, at least generic. And there's concern that at least at this point, the supplies may be insufficient. So if you open it up, then the high-income countries will not, as of yet, have sufficient vaccine. I think as we see everyone in some of the high-income countries vaccinated, just like what we saw early on with antiretroviral therapy, we're going to see a big change in that suddenly many of the high-income countries will be more magnanimous and generous with the vaccine once their populations have been vaccinated. So the last slide, how am I doing for time? Good, I'll have just 2 minutes. There's been a lot of this, I published just a commentary a week or so ago in Nature Medicine, looking at could the pandemic be used to finally reform some of the humanitarian response. I don't know in Tel Aviv if you've been discussing this in terms of the decolonialization of aid. It's been obviously a big topic. London School of Medicine, London School of Hygiene and Tropical Medicine really brought this to the forefront. And we've all been discussing the decolonialization of aid. Black Lives Matter and how that's affected, not just here in the US, but globally now, which was also quite interesting. There's now a push towards trying to see how we can, what we call localize aid, give more funding and capacity to the countries. Could something like COVID be an impetus for doing something like that, given that we didn't have the same sort of surge response. We couldn't because of COVID that we did see for Ebola or for, let's say, even cholera in Yemen. Could we see that, could we use the localization, the nationalization to show that how the international NGOs and the UN actually responds? Can this be different in the future? Can we provide more technical support as needed from afar, and then we don't actually surge in, and that local governments and institutions actually start taking care of this more? This has been a goal for a long time, since the World Humanitarian Summit, but it hasn't happened. For this to happen, my experience has been that organizations are not going to, just like any other, perhaps with self-interest, are not going to voluntarily give up power, are not going to voluntarily give up funding. It's almost organic that one wants to grow and have a little bit more power and hire more people. So this would have to come from the funders. But there are a tremendous amount of barriers, including more and more the requirements of funders to have much more transparency, to be able to, and understandably, to be able to have a report from a fiduciary manner in a very stringent way. And it's very hard for some governments, in particular some national NGOs, to be able to do that. So while I'm not necessarily hopeful that this will be a major humanitarian reform, I'm hoping that this and what we've seen and what we've noticed now through COVID can act as an impetus, even if it's for a limited amount of reform over time, to move more towards localization. So with that, I'm going to stop. This acknowledgements throughout. We've been working with a huge amount of, large number of groups who have been instrumental in helping us shape our thinking. I'm going to stop share and hand over back to you. Thank you.
Gloria?
Thank you very much, Professor Spigel. I think this has been so intriguing and so educational, and we'd now like to open it for varied questions. First of all, anyone here in the audience would like to raise a question?
I have two questions.
Go ahead.
Yes, hello everyone. Thank you for this presentation. I have two questions for the presentation. One of them regarding the situation in Bangladesh with the Rohingyas. As mentioned, there was a peak and they live in a density with highly populated population and lack of hospitals and hospital beds. What is the medical recommendation for such a crisis? Are there specific medicine that are provided, preventive or measures that are given to those people there in those countries that have less access to quality healthcare as in the Western world? And the second question that I had was in terms of the vaccination that was mentioned about the immigrants in America, but also in other places. I think that one of the major pain points that we see globally is the production of the vaccine, is not the will of vaccination, and is the prioritization of the population. So what is being made in order to advance the logistics side, to distribute and to vaccinate in order to avoid more variants and contagion in the future?
Would you like me to respond one by one?
Please. Thank you. Thank you so much.
Okay, let's maybe start with the vaccine. There was a lot of forethought, which is wonderful in terms of, you're probably all familiar with COVAX and with Gavi and WHO, UNICEF, Gates Foundation. So there was a lot of thinking about this. And even within COVAX, which is a facility that governments, more wealthy governments, pay into, and a certain amount of vaccines will come to them, and a certain amount will go to more low-income countries. And even within Gavi, relatively recently, there's what's called a humanitarian buffer. and I think it's about 2% of all the funding goes to humanitarian buffer. And I was on a panel a couple of days ago, and an expert was talking a little bit more about that. The problem has been that the the COVAX has just not received the amount of funding, not even close to it, because understandably, in some ways, it's a pandemic. And so unlike when you have more a regional emergency, which is not affecting everyone globally, I think governments are more willing to be able to step in. Here, governments are really just taking care of their own populations. And in some ways, that's understandable. That's what a government is supposed to be doing. You're supposed to be taking care of your own population. And obviously what we've seen across the board, the political implications of not taking care of your own population and therefore being voted out of office or is huge. And so although there is COVAX, it's extremely limited. We've seen a very limited number of countries, actually Jordan, your neighbor, being one that with limited amount of vaccines have actually been giving to refugees as well. But most countries are not even close to considering giving to refugees because they're not do not have sufficient vaccines to even vaccine their older populations and their healthcare workers. So the thinking was there. It's not like this was ignored. I think the intentions were very, very good, but the funding it's not just the funding, but it's also this supply limitation. There just is not enough vaccine for everyone, and therefore the governments are going to be, the wealthy governments are going to be providing for their populations before they will even consider providing elsewhere.
So for what you are mentioning, and it's the same for different type of industry, we may encounter the same issue with food distribution in a while, but at this point, I think that little effort has been made in terms of government to provide to open new facilities for production of the vaccines. And, I see that in Europe. I'm not just looking at America. For example, Belgium is the center of production of the Pfizer. And Belgium has not even received enough Pfizer doses, and they've been distributed globally. In the beginning, they were like, okay with that, but eventually down the line, they don't even have vaccine for themselves. So, I don't know in terms of logistic how long it takes to develop a manufacturer and to install the machines, but what seems to have been missing is to develop the facilities for production in the first place, because there's a shortage of vaccines. And the pandemic is not going to stop after two jab. It's going to probably last another 2 years at last. So we really, and as you mentioned, it's a global pandemic. Everyone in the world needs to get vaccinated in order to reduce the possibility to infect more. So I really wonder in your capacity and the kind of meeting that you are having with governments and brainstorming together, I understand there's COVAX and they lack funding, but they wouldn't invest in building jobs, manufacturing jobs for vaccine in each country?
I can answer it, but I'm not a vaccine expert. But from what I understand, for example, the mRNA vaccines, as you know, are incredibly complicated. So, and with the problematic aspect of cold chain, it's extremely unlikely that the mRNA vaccines are going to be appropriate or even to be able to be rolled out in, let's talk, the poorest countries. So we need to move more towards AstraZeneca and the J&J vaccine. And I don't know enough about the Russian and the Chinese vaccines to comment, but the key component, I believe, besides just the confidence building, will be the distribution and the cold chain. So AstraZeneca has had as we all know, some horrific communication issues throughout, and I think we'll learn from that. But AstraZeneca, if I understand correctly, can just be done through a normal cold chain, but still needs 2 jabs, whereas J&J is 1 jab. So we'll see how this moves forward. But the it's not just a matter of opening up more facilities. One is the components and the capability to do it, and then number 2 is also been the big corporations, not actually, this is what I meant with the TRIPS agreement, the idea of saying that in a public health emergency, anyone can start manufacturing these vaccines. That's being discussed at the World Trade Organization and other bodies, but Europe and America, for the most part, and the companies that are making these vaccines currently are saying no, and they're being supported. So I think over time, we will see that, but there's a mixture of, it's very complicated in terms of logistics, the complexity of making these vaccines, and also the supplies. My understanding from a colleague in Argentina is that Argentina makes a certain amount of, for Pfizer, I think, no, I'm sorry, Moderna in the US, but they have to send it to the US for one component in terms of the packaging and other areas. So it's complex, and there's not going to be an easy solution. I don't think though the answer is just that we need to be able to have more factories to be able to do this. It's the whole licensing, and it is the components, some of the components to make some of the vaccines, particularly the mRNA, are in short supply.
There's a big work on every aspect of the value chain, from manufacturing, distribution to yes. And the other question I had was regarding your.
Galit, we want to give other participants
so much.
and
Very
Naftali raised questions from a different angle. He actually stated that the problem in many of the areas is that they suffer from different types of complexities. For example, not only the pandemic, but also the climate change or financial constraints and so on. And his question is, what in your opinion is the way to actually tackle all these different constraints together, and how is it possible to build resilience in those countries?
That's a great question, but it's incredibly difficult to answer. And so I would say, I mean, we're everyone is interested in climate change or the climate emergency. We're having direct effects now, but clearly, but that's going to be, we need to act now for longer term. I think one of the bigger issues will be looking at, for me at least, trying to tackle this problem is looking at the context. So what's happening in Lebanon right now has been extraordinary in terms of both the politics, in terms of then the blast in the harbor, and then finally now the free fall of the Lebanese pound. So that is compacting everything in terms of how Lebanon is responding to this. It's also dramatically increasing the stigma against the Syrian refugees, understandably, that are there. So in terms of, I think at this point we need to deal with the immediate problem while considering resilience and the effects of climate change in the medium and short term. One of the areas that I think we need to consider is, there's a lot of discussion. Many parts of Africa put people under quarantine very, very early on. And it's very difficult to be able to, in countries where you have people that are living day by day, literally day by day, and they need to be able to move and just to be able to feed themselves. We need to better understand how to do a smarter quarantine, when to do some sort of quarantine to stop people from moving, particularly when people need to survive, and there isn't a government that is going to be able to have a package to be like what's happened in Europe and the US. And I frankly actually don't know in Israel but I imagine in terms of providing social insurance, most other governments are not able to do that. So what we would like to be able to look at least, and what we're trying to do, is look at the direct and indirect effects of COVID, and we're plotting out all the policies. What did the governments do and when, to try to see if we can find some trends. But unfortunately, it's a massive problem. And a lot of my basic answer is, I don't know. We also, just to say, hopefully the pandemics I think we're going to see more and more pandemics. It's not going to be every 100 years. It's going to be more frequent. So we need to be able to deal with this. But some of the unique aspects that we are talking about is because it's a pandemic, and we saw a completely different response to Ebola and other areas. So I think this is a rather rare issue in terms of what we're going through, but I think it will become more common.
A very challenging question, as you said, and a very, very challenging answer. Valerio is here. I hope you can see him. He is one of the international students here in Israel, coming from Italy. So please, Valerio.
Hi, good afternoon. First of all, thank you very much for this interesting meeting and lecture. I wanted to ask, in your opinion, if this pandemic will change the way that the Global Camp Coordination and Camp Management Cluster will design future refugees camp in order to prevent these problems?
Yeah, I hope so. I mean, even before this, when I was at UNHCR, the CCCM cluster was under my purview, and we shared it. UNHCR shares the CCM with IFRC. You may be familiar with the International Federation of Red Crescent. So there has been discussion now for a long period, a long time, of changing the way camps or people living in schools, you know, in churches and other areas and mosques, because that often happens when you have an acute situation. So it's not just camps, but it's rather people living in congregate settings. There's been a push, I'm trying to remember the name now, it'll come to me in a sec, a master plan approach, where trying not to develop a camp in a isolated area where it's circumscribed, but rather thinking about the needs of where this, let's say, where these people have moved to, what are the development needs of the host populations, and can we, number one, the first question is, can we avoid doing camps? But then number two, can we avoid parallel systems of education, of healthcare centers? Can we actually work? You're probably familiar with something called the humanitarian development nexus, and trying to look at and say, can we improve the local schools and the local clinics, healthcare clinics? Where are the markets, and can we try to work in a way that will improve in the shorter but also the long term the development of the host populations? I think we're already seeing that, but I think it's going to depend, number one, on the magnitude of the response. When you have 100,000, like look what's happening in Tigray right now, where you have a huge outflow of Ethiopians into Sudan. There, you have to be able to do something very quickly because people need the basic sustenance and care. So that's number one. So it's going to depend on the magnitude. And then number two is it depends where they may go, where they go to. If they move in an area where at least there is some minimal infrastructure, it may be easier to plan looking at the development of that area and do something more specifically. But if they're really in the middle of nowhere, it sometimes, in order to save lives, you do set up all these poor camp settings which are very poorly developed. And then finally, one other area that I'd like to talk about is innovative financing, because what we see consistently is there's never enough money. And so when, for example, I spent a lot of time in Zatri and Azraq camps in Jordan, but early on when we started to develop the Zatri camp, there just was not enough money for basic water and sanitation. So the infrastructure that was built was very poor, that needed a lot of upkeep. But the problem is there is not enough upfront money to address the capital costs to do a proper infrastructure of a water and sanitation for a place like Zatri, that 10 years down the road, when you look at how much the costs would be, it would have been more cost effective to do it better at the beginning. But that's a problem of investment, and there isn't an easy way to be able to address that, particularly when most governments will never agree to say, you're right, likely these refugees are going to be here for 10 years. Most still call them guests and hope they'll be gone after 1 year.
Any other questions from one of the students here or the participants? As I can't see all of you in the screen, if anyone has a question, please go ahead.
Question is, even if we have the vaccination to give it to the refugees and other places that are not available, the logistics around it is going to be the amount of money just to buy the vaccination. It's not enough. You need to have the whole system to distribute this vaccination, and it's also give a lot of power to maybe bad governments or regimes that will take care of it. And this is also something that we need to take for consideration.
Yeah, I would add, so I think one is it depends on the vaccine, and particularly if there is a vaccine like AstraZeneca, which we can use existing cold chains for, it will be much easier because in many of these such settings, the refugee settings or in just low-income countries, they do have a relatively strong and very basic expanded program of immunization. So that may be doable. I mean, what's interesting is in places like DRC and other areas where they're used to doing, in Yemen, where they're used to doing contact tracing for cholera, for Ebola, it was actually easier for them, I think, to be able to, they had these systems and community health workers in place, where here in the US, we didn't have anything like that. Our surveillance system, public health system, I shouldn't say the Americans, I'm a Canadian, but it's been different. So we were not able to respond in certain ways. So certainly an mRNA vaccine, no way it's going to be appropriate in many of these areas, maybe only in some of the capitals. But a more simpler vaccine, I think that they would be able to be rolled out. And I don't think some of the simpler, I think that eventually there will be, just like we've done with antiretroviral therapy and just like we've done with other vaccines, probably the costs will be paid for by donors and others. And UNICEF, and even some of the logistics of WFP will be able to, World Food Program will be able to help. So I think it depends on the type of vaccine, but a lot of these basic systems do exist in very remote areas. You are able to bring out cold boxes and deal with very simple EPI, expanded program for immunization.
Professor Spigel, I'd like to first of all thank you on behalf of all of us, all the participants that we're lucky enough to have this opportunity to hear of your vast experience and you know the insights that you have learned and shared with us. I think this has been both on a professional level and on a personal level a unique opportunity, and I would like to thank you for being with us here. I have to say, we forgive you for studying in the Hebrew University and not in Tel Aviv University, but we do want to invite you in the next time that you're in Israel, or if we could schedule a special time for you to come to Israel. We would love to have the opportunity to host you here and have you speak again with our students and our faculty, actually, which and no doubt is something that we have so much to learn from you, and thank you for your readiness and willingness to voluntarily be with us today. I want to say two more words with your permission. The initiative to this meeting was done by the SID Israel, the Society for International Development, and Dana Manor specifically was the one that reached out to you. She heard you in another lecture. She said, "It's fabulous," and she was right. We have to hear him. So I would like to thank SID that collaborates with so many different entities and strives all the time to improve both the humanitarian action and the international development, including the cooperation with us in Tel Aviv University. And one of those collaborations during the COVID-19 was to look at another angle. You very correctly spoke about the vulnerable populations, the countries in which they're actually being hosted, not always to their satisfaction and so on. We looked at another angle, which SID was interested in, and that was the providers, those civil society organizations and the non-governmental organizations that even before the COVID was in many of these humanitarian settings, trying to help and provide life-saving and crucial, vital services. And what happened in the COVID-19 was that they were very much impacted. And together, SID actually initiated the study on those organizations. We covered more than over 400 of those organizations. And what we found is that not only were they impacted by financial constraints, there were less donations, as well as the need for physical distancing made life more complex, but also because of lack of information and lack of cooperations between the local administrations and governance systems with all of these organizations. So there's certainly a lot of place to try to work on that in order to actually facilitate a better provision of humanitarian response in humanitarian settings. So I think this is also a crucial element. And again, I want to thank you. I want to thank Sid. And I want to thank all the participants that were with us here today. And we look forward to having this opportunity again. So hopefully we just opened the door, Professor Spigel, and you allow us to reach out to you again so that we can learn more and more from your experience.
Great. Well, thank you. With a pleasure. And thank you for the wonderful questions. And look forward to seeing you all in person.
Thank you.
Thank you very much. Bye-bye, everyone. Alon or Dana, do you want to say something before we close the webinar?
Just thank everybody, and especially Professor Spigel. Thank you so much.
Thank you, everyone. Bye-bye.
Thank you.